So CKD and CAD both are highly prevalent in our country. If you see the chronic renal patients, they are associated more aggressive disease. We often encounter more aggressive multivessel disease, more calcific disease compared to non-CKD patients. Altered creatine and low GFR patients are very difficult to treat. Honestly, it is not only for the coronary disease, even it is for the diabetes patients. Any patient with the 2 creatine, very difficult to manage diabetes because many drugs are contraindicated. Patient with the low ejection fraction, LVF and altered creatine, again we stuck out. Why? If we give the creatine, it increases the if we give diuretics, it increases the creatine. AC inhibitors and Vimad are also relatively contraindicated in such a patient. So, very difficult to treat LVF. If you see the 7 major criteria for the pre-op assessment, for the non-cardiac surgery, altered creatine more than 2 is one of the major risk factors. So any patient with the altered creatine, they are having chances of having adverse event during the post-operative pathway is very high. Coronary intervention, angiography usually require contrast or dye, which again create a negative impact on patients. CABG, normally આપણે એવું માનીએ કે CABG માં તો કોન્ટ્રાસ્ટ નથી કરવામાં આવતો, પણ CABG is performed in 2 ways, either off pump or on pump. Beating that or off pump, normally surgeon has to create very low pressure, 90 to 100 throughout the operations. So this again have very bad impact on the creatine. So patient with the 2 creatine beating heart, if you see the post-operative trend of the creatine, they are normally having very rising trend. Sometimes patient require dialysis also. So all the procedure along with the altered creatine create a very bad impact. This is one of the major studies in which CKD patients, normally they are usually very lately referred to us. કાર્ડિયોલોજી ને એવું કહેવાય કે તમારું ક્રિએટિન નોર્મલ થાય પછી તમને એન્જિયોગ્રાફી કરાવીશું, પણ મોટાભાગના બેઝલાઇન ક્રિએટિન જ હાઈ હોય CKD માં. સો ઇટ ઇઝ વેરી ડિફિકલ્ટ ટુ બી નોર્મલાઇઝ, લાઈક 1.1 થી નીચે, GFR 40 થી ઉપર, એ બહુ ડિફિકલ્ટ ટુ અચીવ ઇન CKD પેશન્ટ. સો દે આર લેટલી પ્રેઝન્ટ ટુ અસ એન્ડ મીનવાઇલ મોસ્ટ ઓફ ધ કાર્ડિયાક ડેમેજ હેઝ ઓલરેડી occurred. In-hospital mortality is 2.5 times higher in CKD patients compared to non-CKD patients, and even low amount of contrast volume can lead to contrast-induced nephropathy or acute renal shutdown. The incidence is vary between the 4 to 11%. So these all create a very negative impact on overall outcome of the patients. So how to deal with such a case? તો why CKD પેશન્ટ આપણે નોર્મલી એવું માનીએ છીએ કે ભાઈ જેને ડાયાલિસિસ ચાલુ હોય ને એમાં આપણે બહુ ચિંતા નથી, એટલે અમે કાર્ડિયોલોજીસ્ટ બી ક્યાં તો ડાયાલિસિસ કરાવી દઈશું, જસ્ટ વી ઇન્જેક્ટ ડાઈ નોર્મલી કે ભાઈ ઇન્જેક્ટ કર્યા કરો, કશો વાંધો નહીં આવે. પણ એવું એનાલિસિસ થયેલું છે કે ઇવન CKD પેશન્ટ્સ, they are having on regular dialysis, they are having some preserved renal function. This is the reason કે કેટલાક પેશન્ટને વીકલી 3 વાર ડાયાલિસિસ કરાવવું પડે, કેટલીક વાર 2 વાર કરાવવું પડે. It depends on the some preserved renal function. So small amount of contrast can lead to metabolic acidosis, hypertension, myocardial depression and overall increase in the mortality. So contrast-induced nephropathy is associated with overall elevated risk of adverse event, including sustained reduction in the renal function. એટલે જેને ડાયાલિસિસ ના અને કદાચ પરમેનન્ટ ડાયાલિસિસ ઉપર આવી જાય, જેને લેસ ફ્રીક્વન્સી હોય ઇટ ઇન્ક્રીઝ ટુ મોર ફ્રીક્વન્સી એન્ડ ઓવરઓલ ઇન્ક્રીઝ ઇન ધ મોર્ટાલિટી. So what is ultra low contrast અને કેટલો કોન્ટ્રાસ્ટ આપણી કિડની ઉપર અસર ના કરે? તો નોર્મલી વી હેવ ટુ કેલ્ક્યુલેટ ધ GFR. ક્રિએટિન ઇઝ નોટ ઇમ્પોર્ટન્ટ. આપણે બધાને ઘણીવાર એવું થાય કે ભાઈ 1.5 જ ક્રિએટિન છે, ઓકે સાહેબ કરી દો ને એન્જિયોગ્રાફી, એવી રીતે તમને મોકલવામાં આવે છે. પણ ઇન અ પેશન્ટ વિથ ધ 80 years, low weight, female sex and 1.8 creatine, it actually acts as a 4 creatine in a normal healthy person. So creatine number is not important, important is the GFR. So we have to calculate the GFR. Like for example, one of the patient is having GFR of 20 So for me, total amount of contrast allowed in such patient is 19 ml. So GFR minus 1 is the total amount of contrast, which is very safe, that study shows. So I have to complete whole procedure, whether it is PCI or CAG, within the range of 19 ml, then this patient has less chances to develop any contrast-induced nephropathy. There are several ways to prevent the contrast-induced nephropathies. We all know that Mucomix આપણે આપીએ છીએ, Sobicis આપીએ, Fabutaz આપીએ, these all medicines, but still they are questionable. Only proven is the 24-hour hydration. So hydration has the proven role which prevent contrast-induced nephropathy. Obviously, if we are having some method which we can prevent the dye injection, is obviously a very good strategy which overall reduce the mortality and contrast-induced nephropathy. So this is the simple image of the IVAS. This is the IVAS catheter. The black one is the intima. This is the black one is the media, and this is the externa. So image is very necessary part of the zero contrast angioplasty. But not only image, there are several other ways by which we can perform this procedure. Let me start with the one or two couple of cases so you can understand in a better way. This is a 70 years old male. Patient is having hyperacute anti-MI, long-standing diabetes. When presented to us, he is having ketoacidosis, 7.2 pH, acetone of 80, very dangerous signs. Baseline creatine is 2.46. So high creatine, severe acidosis, diabetic, acetone more than 80, and hyperacute anti-MI. What to do? Because MI itself, if we left untreated, this patient definitely going to deteriorate, and this patient definitely induce some cardiac complications. So we have to do something. At the same time, if we perform the routine angioplasty, the chances of survival is again very less, because in a severe acidosis, if we inject 70 cc or 100 cc of contrast, which normally require in a PTCA patients, this patient is definitely not going to survive. The outcome is very poor. So what we have done, we normally in such case, we just perform with the help of 2 cc dye just to see the anatomy, to see the any anomalous origin of coronary is there or not. So this is the thing, this is the LED which shows complete occlusion from the proximal part, and RCA which shows normal. So patient is having 100% LED occlusion, circ normal, RCA normal. So this patient is having hyperacute MI. Now we just remove the manifold. Manifold એટલે પેલું contrast inject કરવા માટે લઈએ, એટલે જેથી ભૂલે ચૂકે બી અમારો જે ટેકનિશિયન હોય એ ઇન્જેક્ટ ના કરી દે. And now we started our zero contrast procedure. So this is all. We park the wire and then we perform the this is the thrombosuction catheter, and after which this is the IVAS catheter. Okay. So we park the IVAS catheter very distal toward the normal segment, and we take the whole image. So, and this is the IVAS image. So this is a very distal part which shows very normal segment. From the IVAS, we can characterize many things like diameter of the vessels. Okay, so this is the distal diameter of the vessels. Starting point of the disease, proximal part of the disease, character of the block. According to character, we can treat the patients. So still it is a normal. See, it is a completely normal. When we proceed proximally, so this is a little bit plaque from the very minor plaque from 6 o'clock to 9 o'clock. Now see the caliber diameter of the vessels gradually increase. This is very normal in our coronary part. Distal part is always having a small caliber. As we proceed proximal, it increase in the size. See, this is the now started block. Very critical thrombotic mixed plaque from overall concentric plaque. Gradually increase in the diameter, same the plaque burden is increased. This is the lipid rich necrosis, thrombotic plaque, very tight stenosis in the proximal part, almost negligible. See, very tight. So this patient is having very tight thrombotic, vulnerable, lipid rich necrotic plaque. So after which we just create a whole plan. This is what LAD is proximally occluded. This is our proximal landing zone. This is our typical lesions. The size of the vessels, character of the block, the distal landing zone and proximal landing zone, all which we map. Here, we all know that this patient is having this proximal part approximately 6 to 8 millimeter away from the left main or circumflex bifurcation or just distal to the septal. This is what our proximal landing zone. We know the distal part from the size of with what we catch from the IVS image. So here, this is the septal vessels 2 millimeter away. We put the proximal landing zone. We know the landing zone. We know the diameter. We know the character of the block. So we take a size accordingly what we get information from the IVS. So we require 3 by 38 Promos element stent, which we put from the proximal to distal landing zone, and then we inflated it. And this is the, after inflation, we again perform the IVS image. See, the whole lesions is completely open. Whole lesion is completely open with a very good distal land flow. And believe me, friend, this patient do not require dialysis. This patient we are able to discharge within 3 to 4 days without any major complications. So take home message is, this patient routinely require around 100 cc contrast, which may increase the acidosis, cardiac depression, arrhythmia and mortality, sometimes aggressive dialysis. And due to this unique procedure, we are able to perform this procedure without drops of single contrast, and this patient is doing well. This is another case, 70 years old male, severe COPD, developed severe breathlessness, orthopnea and chest pain. Blood investigation shows the troponin I, altered creatine, low GFR, high SGPT, low ejection fraction. So all the high risk characteristic of this patient. The same things, see, this is the one contrast and this is another contrast, that's all. These patients actually this patient shows multi-vessel disease actually, very tight circumflex lesion, very tight LAD from the ostium. So we require stent from the left main to RCA also shows the disease from the ostium to proximal part. Here the same thing what we have performed. See, despite of multi-vessel, we thought we are able to perform in a zero contrast. So we just park the wire, we inflate the balloon, low pressure balloon, and then we again proceed with the IVS studies. This is the IVS catheter, and we proceed with the IVS studies. Here the IVS studies, it shows a relatively, this is the distal part which is clear, but here this is some branch which merged with the IVS. Here the little plaque has started. So we know the distal LD landing zone. Now see the plaque from the 6 o'clock to 12 o'clock. It is little bit fibrotic in nature. Very severe tight stenosis. Very severe tight stenosis. Here little bit lipid rich necrosis is also there. So as we proceed, the diameter of the vessels increase. The character of plaque we can know. the severity of plaque we can know. Again, little bit LD segment. So there is a skip lesion. So there is one lesion in the distal. This is little bit LD lesion. The whole, this is the LD artery. Can you image the difference between the size? The distal is 2.5 in diameter. This is 3.5 in diameter. Okay. Now as we proceed, again, there is a little plaque from 4 o'clock to 7 o'clock. Here the plaque burden is from the 1 o'clock to 3 o'clock. Now there is a tight stenosis again, very tight stenosis. This is the lipid-rich necrotic burden. Now this is the proximal part of the, this is almost 3.5. This is almost 4. So very mismatch in the size. The block is fibrotic and mixed nature, fibrotic and calcific. Again, this is the proximal part which shows the plaque burden again. So there is a multiple skip lesion. See, this is again shows the plaque vessels. Now this is the LD zone. This is complete LD zone. Now we can see the, you can appreciate, this is a very mild plaque, less than 50%. This is the merging of the LAD, and now it's a left main. This is the left main vessels, okay? So left main is little bit distal plaque is there, but overall it is a LD in nature. This is the little plaque from this 12 o'clock to 2 o'clock. So very huge left main, very huge left main. Again, multiple skip lesion. The diameter, see, there is a multiple skip lesion. One lesion is over here, one lesion is over here, other lesion is over here, other lesion is over here. There is a significant mismatch in the size also. So what we have to do, we have to prepare the bed. The fibrotic bed required a cutting balloon, so we use the cutting balloon and prepare the bed. This required the NC balloon, we dilate with the NC balloon. So according to information, we prepare the coronary bed. Then we choose the size. We know the proximal landing zone, we know the overall diameter of the size from the IVS image. So we take a long stent which covers the whole lesion. So 48 millimeter is the longest lesion. So we take that. We know the proximal landing zone. It just...
Sir, please conclude.
Yes. So my conclusion is, see the results, okay? The whole things we are able to get a very good results from distal to proximal. Our characteristic, our all diameter we are able to achieve. And we perform left main, circumflex, LAD and RCA, total 4 stent with the help of image, with the help of landmark, with the help of this wire and balloon technique, without introduction of 0 drop of dye. And this patient is, again, we survive from the this dialysis and other complications. So this method we can perform all type of complex cases. Zero contrast is a, might take a message, any patient with the altered creatine, do not afraid કે તારી angiography નહીં થઈ શકે, angioplasty નહીં થઈ શકે. પેશન્ટ ડાયાલિસિસ ઉપર હશે, એની બી આપણે એન્જિયોગ્રાફી બહુ સરળતાથી કોમ્પ્લિકેશન વગર કરી શકીશું. We have performed CTO, we have performed rotablation even in the zero contrast. We have performed multivessel stenting, fibrotic lesion, IVL therapy, zero contrast. So this is the new technology, and one should appreciate that new technology for the patient with the altered creatine. Thank you.